Good afternoon, everybody. Welcome to today's meeting of the Health and Wellbeing Board at the London Borough of Hillingdon. This meeting is being broadcast on the Council's YouTube channel, Hillingdon, London. My name is Councillor Jane Palmer and I am co-chair of this board. Before we start, I've got some important housekeeping for everybody around the table. Could you please ensure that your mobile phones are on silent? We're not expecting a fire drill, so if the fire alarm does go off, please follow, that's going to be Ryan, out of the building. Please keep your microphone muted when you're not speaking and then unmute to speak. It is worth noting to those of you that are watching that some members of this board may be using devices to access the agenda and papers for their meeting, so that's what they'll be looking at, not anything other than that. So if we now move on to the agenda, agenda item 1, apologies for absence. Do we have any apologies? Lovely. Welcome, Amanda. Nice to see you around the table. If we go on to agenda item 2, declarations of interest in matters before this meeting, other than those already declared on the register of interest, are there any declarations of interest today, please? I'll take that silence to be a no. So we can move on to agenda item 3, minutes of the meeting which are before us on the 18th of March. Does anybody have any comments on the accuracy of the minutes?
Top of page 5, Tony Zaman looks like he's going through a transition of gender. So he'd like that to be corrected.
Thank you for your observation. I shall move swiftly on with that comment, but I'm sure Nikki has that documented. Thank you, Professor Goodman. Any other observations on the accuracy of the minutes? Lovely. Are they agreed? Those minutes are agreed. Thank you very much. I just need to say on agenda item 4 that the exclusion of the press and public, that I'm going to confirm here that items 5 to 8 will be considered in public and items 9 to 11 will be considered in private. Moving on then swiftly, we're going quite swiftly at the moment, which is quite frightening. Agenda item 5 is the Hillingdon Joint Health and Wellbeing Strategic Priorities Dashboard and Progress Update. So this is an amalgamation of what had already been planned as 2 reports, the Health and Wellbeing Strategy and the Health and Wellbeing Board Dashboard Reports. So is that you, Keith, please? Thank you.
Thank you, Chair, and good afternoon, colleagues. So you'll recall from our last Health and Wellbeing Board, we had a very lengthy discussion about a draft set of priorities, and I think it was the wish and will of the board that we had a smaller number of priorities with a clearer focus around the metrics about what success looks like. So what you've got in front of you today is a draft of that for your approval. There are 3 parts to the paper which I will talk to. The first part sets out the 5 proposed health and wellbeing priorities. The second part of it sets out the progress with implementing those priorities that we've got. And then the final part, at the back of the deck, you'll see a series of metrics and diagrams, which what it's meant to do is obviously give you some quantification of where we are with that progress. So, unapologetically, I put onto the first slide a summary of the health and wellbeing and priorities, and we are proposing 5 priorities, as you see set out from the deck. One is around starting well in terms of improving early years outcomes, reducing childhood obesity, and promoting readiness for school and life. To live well, which is to prevent and or delay the onset of long-term conditions, particularly hypertension, and improve mental well-being. The third one, to age well, which is about implementing at scale proactive frailty management and better end-of-life care. The fourth one is around developing healthy places, so tackling housing, environment, employment and social isolation. And then the final one is around equity and inclusion, around targeting resources and interventions where inequalities are at their greatest. Now, again, what we are proposing, and it's up to the board to decide that that's right, is rather than try and operate and on all 5 of those priorities, what the proposal is that for the first 2 years of the strategy, we focus on priorities 2, 3 and 5, and they're the ones that are italicised in the document. That's in terms of living well, and that's fundamentally about how we prevent ill health, how we preserve independence for as long as we can, and prevent the onset of long-term conditions. To age well, which is about how we address people when they do become unwell, and that's in particular people who are at risk, significant at risk of a hospital episode or admission to long-term care. And then the final area, and we had a lengthy discussion last time, was around, rather than boiling the ocean, is whether we target what we do and put whatever resources that we have at the area of greatest inequity. And we've had a lengthy discussion, I'm sure we'll come on to that in a moment, around some of our poorest neighbourhoods in Hillingdon. I will pick up chair through you, if I may, agenda item 7 on the agenda, wrap it into this discussion here. So they're the 5 strategic priorities. So I guess the first decision point coming on later for the board will be, are you content with those 5, and are you particularly content with prioritising a small number of those in terms of where we put our resources? What I would say, it doesn't mean we don't do any work in those other 2 areas, but it means we major on a smaller number, and I think that was the will of the board last time, was to focus on some of those bigger ticket issues. So those 5 strategic priorities, or the 3, are delivered through the implementation of our 7-day place operating model, which has 2 big key transformation schemes, and that's set out on page 11 of the report. And if I put it into plain English, those 2 priorities are focused on preventing crisis in the first instance, working long term with people, and then secondly, responding to crisis. And in terms of preventing crisis, you will know that our focus is around implementing 3 co-located, multi-agency, integrated neighbourhood teams. And what I would say is, you did hear it first here, long before the government adopted this now as their strategy. We have been talking about this now for some time, and we are well along this route. It has 3 core areas. The provision of same-day urgent primary care. Now, this is an issue, Chair, particularly for you, is around access to primary care, how we improve access to primary care in order to prevent overspill into our acute hospitals. Proactive care, and that is around how we case manage, how we target and work with people who are likely to be at risk of either admission to long-term care or non-elective admission. So they already have multi-morbidity, and what we're trying to do, so I should say that they have more than one long-term condition, multi-morbidity, and how we keep and manage them in a community setting. And then finally, an area where I think we agreed, we really have not done an awful lot in terms of that long-term work about how we prevent some of those long-term conditions developing. They're the 3 strands of the neighbourhood work. And then the second component of it is how we respond to crisis. So when people do become ill, what is our community place-based offer to people who become ill in order to prevent them being either admitted to hospital or going into long-term care? And then secondly, if they are admitted to hospital, how we enable them to be discharged early and live as independent a life as possible. On the opposite side of that table is what we are proposing as the key metrics. Yeah. It's not because other metrics are not important, but I don't know about you, Chair, but I have a problem with having 36 pages of key performance indicators which come across. So what we've tried to do here is be clear or clearer what those key metrics are. And those key metrics are being built from a number of sources. One, they're built from the hospital redevelopment programme. So some of those are the numbers in there which we have to hit in order to make sure that the new hospital, when it's built, isn't too small. Secondly, they come from national targets in terms of, for example, if we take reablement, these come from BCF targets, flatlining permanent admissions to care homes, enabling THH to operate within a target bed base of less than or equal to 412. Again, that is part of the hospital redevelopment proposal. So we're trying to hard code some of those metrics in there. The bottom metric is something that we've been working on, is in terms of hypertension. Again, we talked last time, I think, Ian, around whether it's hypertension, is it excess weight, what is it we should be focusing on. But there is a really strong evidence base which says in a national target is that actually we should basically have a prevalence rate of around 30%, and an optimisation rate around 80 to 90% in terms of hypertension. And again, and what the impact of doing both of those, it reduces non-elective admissions by about a third for that client group. So that's the long term. So again, second decision point I think for the board is, are you satisfied with those? Is the metrics on the basis that we can always bring in other metrics, and we will do, but we need to be focused on those metrics which are involved in our big strategic shifts that we're trying to enable. What we then do is I turn over the page, and if you, onto pages 12 and 13, it gives you a progress report against each of those two areas. And if I was to summarise it for brevity purposes, if you take neighbourhood development, we do well compared to both national and local benchmarks in terms of two areas. In terms of putting the infrastructure in place of neighbourhood health, we've done a lot of work in there, and Amanda may want to talk about that later. And in terms of some of the numbers that we've got there, we have some really good numbers in terms of proactive care and the impact that enhanced case management has on non-elective admissions. The challenge for us, as you see from the data, is we've only got half that number of under enhanced care case management that we need to have under that. So I think we do well in that area. The second area where I think if we were to mark our own report we must do better is on the reactive care. So it's the work we do to keep people away from the hospital front door, and the work we need to do to discharge people earlier and prevent them going into long-term care. We do well against North West London benchmarks, but the North West London benchmarks I think are generous in this area, and we just need to do better on some of those areas than we do, and we're suggesting that we need to ratchet up or down some of the targets that we've got there. And what I will draw out, Chair, just in terms of, you can see the statistics for yourself, but I think the key thing I would just show is in terms of our Care Connection teams, we are case managing the top 2%, around 5,000 patients, and in terms of the admission diversion for those areas, they're actually very good if you look at the data. The problem for us is that there's just under 10,000 people with severe frailty, and we're case managing half that number. So the plan for us has to be is how do we ramp up the case management of the other 5,000 in a cost effective and targeted way. And the second area, it says of hypertension prevalence, we're currently at 13%, which has been major progress that's been done by the team. We need to get that to 24%. That is the target, that's the national target. Of that 24%, 80% need to have their blood pressure controlled. And they're the numbers that begin to move the dial. In the second area, in terms of reactive care, if you look at the front door area, we're significantly away from the targets that we have in terms of the hospital redevelopment programme. We are currently seeing around, on average, each day, 34 patients in ED more than we should be seeing in that time period. And I think what we need to do, and I'll come on to this in a minute, is what is our plan to manage that demand from the front door. We'll come on, and I'll come on to that in a moment. So we don't do as well there as we should do. I'm sure Vanessa will comment a bit about the work we're doing on the Lighthouse, about the mental health patients who are coming to the front door ED, and the work we've got there, because again, that is shallowing against where we want it to be, and the plan has to be around, I think on average, Leslie, it's about 9 patients a day are coming to the ED department, and we're currently seeing around 1 a day in the Lighthouse. And Vanessa's, I think, and the team have worked on a new approach in terms of tackling that. The other area I want to draw to the board's attention is we've done a demand and capacity review, and that's been a multi-agency piece of work. We've worked with the hospital, we've worked with adult social care, we've worked with primary care on community services on that. And I think it's fair to say we have neither the capacity nor the capability in our teams to do the numbers that we need to do in that area. We see around 3,500 we see around 3,500 patients a year, referrals a year, in our urgent community response. That's a broader range of services than just our rapid response services. We need to be seeing around 7,000, double that number, in order to have the impact on the front door that we need to have. And we have we have the skills in the system. They're just spread across a range of different services. So we have a plan to do things differently in terms of that, in terms of bringing that service together in terms of reactive care. So, for example, our current team is largely a nurse-based team. It doesn't have any respiratory physiotherapists working as part of it. It has no access to adult social care, emergency therapy as part of that, and actually little access to primary care advice. So one of the things we're trying to do is a new model of how we fix that going forward. And in the short term, at this month, it is June, isn't it? As a start of that, we will bring live an intravenous antibiotic service through the Confed. Colleague, I'm sure Amanda will talk about that, working with our colleagues in CNWL. So we're starting to try and turn this around, but some of those numbers are quite stark, just in terms of what we do. And you can see the metrics on the right hand side of that. So we have a plan to do with that, but actually there's work to be done. I think it's fair to say, Chair. So what I'll do is pause there, and I guess it would be good to take feedback on is this in the right area, because I think we wanted a slightly more dynamic at root cause discussion as opposed to saying everything's lovely in the world. So I'll pause there and take views on the report, the metrics, are there things missing. This has been through chief finance officers at place level last week, and they've made comments on those too, which we'll take into account. But I'll pause there, Chair.
Just turn the mic off for me. Thank you very much, Keith, for leading us through this, and I just would like to thank the people that have sat round the table to make this possible. This is a really, really good step forward for this board to see something, albeit very, very tiny. I might need to visit the opticians to enjoy the best of it, but I would just like to put on record that this is a fantastic start of a piece of work that we need to be doing. So I'm now going to ask for comments. I think we need to really discuss this, Keith. I've asked a few questions out there. So does anybody want to comment? Sandra?
Thank you. I would support the 5 priorities. I think they're the right priorities, and they certainly, from an adult social care perspective, I can see that they dovetail as part of our place response appropriately, particularly the hypertension points, which are really noticeable. It hasn't been over the last year, 18 months, we can really see the number of people coming into adult social care as a consequence of significant stroke and as a result of hypertension. So any work that we can do to improve that we can align with public health and the support that they can give in that type of work, then I think that that's a really positive step forward. Just on the priorities, that I support the fact that we're going to do targeted and kind of universal in terms of the early help and start for life for children and young people. But this is an area where I think the local authority are doing significant work, and we've got some really good kind of change data that's showing good outcomes and outputs in conjunction with a whole host of people, particularly CNWL at the moment, that means that actually there is stuff going on in the background. So I don't feel that the 1 and 5 in the priorities list are orphaned. They actually are well covered, and there's other stuff that we can be doing in the background that ticks along as well. And I think public health can support all of that work as well. So thank you, Keith.
Anybody else wish to comment? Please, Leslie. Well,
thank you, and apologies for being late. So I guess there's something that says, no problem with the priorities at all. And Keith, I think, worked out really well across the system. I guess there's something about the timescale for what do we believe is realistic delivery, and are we clear where responsibilities lie for doing each bit, and including actually where the acute unit needs to step in. And of course, I heard as you were coming in the reference to the new build, and of course the truth of the matter is it won't be big enough for us if we don't manage to deliver this. So there is something really important for all of us that says, how do we do all of those bits? And just to say, our commitment at Hillingdon is to absolutely contribute fully, both in the hospital but out of the hospital as well.
Thank you. Lynn?
Thank you. I agree it's a really good piece of work, and the 5 priorities seem to fit together very well. There was a report today actually from Roy Lilly, who said that the under 1s are now the greatest users of A&E services, and it's attributed to many things, including reduction in numbers of health visitors, etc. And I wondered what our position was in Hillingdon regarding this, and whether or not this work's being factored in.
Shall I start, and I'm sure Leslie will chip in. So the piece of work we've done with colleagues at the hospital is there's a tendency to boil the ocean when we're tackling this. So there's a number of areas we've identified in terms of a focused bit of work. One is mental health that you've heard about. The other is the reactive care, and the third area is children. So rather than, it goes back to the targeted work that we're doing. So there are 3 focus areas that we're trying to deal with in terms of people presenting to ED. Go back to Sandra's point, it is then about what are we doing much earlier. It's not, once they got to ED, you can argue that's, we've failed. So it's targeted bits of work that we're actually doing with some clear numbers, because percentage-wise, I'm sure Leslie and Sean will tell me, children attend ED are a smaller percentage, but they're a significantly growing percentage of that work.
Leslie?
So thank you for those. I'm interested that you read the Roy Lilly work. I think it's actually calmed down over the years, personally. But anyway, I mean, if he's to believe that more or less says nearly every child goes to ED, and what that particularly under 1s, and what that probably says to us is not that the under 1s are any sicker, but actually the preparation for mothers and for families is something we really need to work on, because there will be a proportion of those we absolutely need to see and we need to look after. And I think it speaks to your thing about health visiting, actually, which is what are we doing to prepare new parents for what is normal ups and downs of having a baby and the normal sicknesses, if you like, of baby. Sorry, that's not terribly good English. And that's probably where we've got to do a bit of work, to be honest.
Yeah, go for it.
Thank you. Yes, I just want to highlight that we are seeing that some of the vaccine preventable diseases are also raising their head. So just last week there was a press release from UKHSA about measles, and measles cases are increasing, and London is bearing almost half of all the burden of all measles cases in England. So I think what we need to do is get vaccinations rates up, and prevention is really important. I've just been to a head teachers meeting this morning to present on vaccinations, and I think we need to, through primary care, we need to just, and through 0 to 19 service, we need to ensure that we have vaccination and screening done.
Vanessa, did you want to make some comments about the mental health?
Yeah, thank you. I mean, I'll start with just making comments about our commitment to the priorities and to having a focus on the few that you've outlined, Keith, because I think that is absolutely the direction of travel. Before I come on to mental health, I'll also just agree with the work that we're doing around the family hubs with the local authority, and making sure that we are still doing that piece of work, but making sure we're focusing on the areas that we've outlined. And also the urgent crisis response from a physical health perspective is something we're really committed to changing and making sure that we up those numbers, because that is a key priority for us. So in terms of the Lighthouse, and thank you for outlining that, Keith, we have I think unfortunately noticed that the numbers have been far too small for us in the Lighthouse, so we have been working with Ritu from the GP Confederation and other partners to look at changing the Lighthouse. So I guess number one is making sure that the people are coming into A&E actually do need to be in A&E. So we need to make sure that we've got that really good support and crisis support for people with a mental health issue only, so that they don't come into A&E. So for me, that's we do need to focus on that as well. So we are looking at what same-day emergency care looks like for mental health, because I think we talk about same-day emergency care for physical health, but we haven't really bottomed out what that looks like for mental health. So we're just working on that, so that people who might come in through the front door to the urgent treatment centre have that same-day emergency care appointment in the mental health team. So thank you, and a call out to Ritu on working with us on that. In terms of the Lighthouse, we are looking at a model where people come into the Lighthouse maybe without having to go through A&E. So it might be when people come through the front door of A&E, or before they even get to A&E, when they come through to the urgent treatment centre, that there's a joint triage and people actually walk around to the Lighthouse. So if people don't know and haven't seen it, the Lighthouse is about 100 yards away from A&E, so it's actually not very far away. It's just that people are taking quite a long time to kind of get through the A&E assessment system before they then come to the Lighthouse. What we want to do is make sure that people aren't telling their stories more than once. We want people to come and tell their story and get the support in the Lighthouse much quicker. So we're working on that. I think, Keith, we've got a system partners meeting on that at the beginning of July, end of June, beginning of July, because actually this isn't just about one team and one service. We want to make sure that we're wrapping all of our services around getting those people the support they need and out of THH as quickly as possible.
Thank you. Can I just ask a question on that? When you're revamping your services, are you using, I'm going to use the word service users, to assist you with that difficulty?
Yeah, no, we're absolutely co-producing. So I've had the pleasure actually of meeting with a number of service users who have used the Lighthouse, but also service users who haven't had such a good experience. They haven't used the Lighthouse and have been in crisis. So myself and the Borough Director, Kingsley, have met with them either individually, we've done it kind of on an individual basis and a group basis, to really understand why people aren't getting the support, and that's helped us frame. I think some of it is about people not knowing about some of the crisis alternatives that are available to them, like the retreats. The retreat is used really well. Not everyone seems to be aware of that, so we do need to make sure we've got a proper comms plan in place around crisis alternatives, but also about making sure the Lighthouse is used appropriately.
Thank you, and using the chairman's privilege to come back to you on that. I think that's very, very important, because a lot for the press at the moment is about what's not available. You know, when we see people in crisis in A&E, and I'm always keen on, you know, inspections and things always show a better way of doing things, whether we like it or not. So I'm pleased to hear that we're using, I'm still going to use the word service user, because that, I think that is, you know, if we're doing unto people, we also need to see the perhaps a more efficient way of doing it. So thank you, Vanessa.
I'll just come back on just very finally, because people probably will have seen in the press actually all the talk about kind of mental health A&Es, I think it's being branded as. So I do think we've got a real opportunity here, that we're already doing something that actually is being talked about in the press. So I think we do have, like you say, we have a bit of an opportunity to make sure that we get it right before other people, and then maybe other people will come and start having a look at what we're doing.
Please, because I think one of the things we don't do very well in this borough is publicising what we actually do. We're all on the same page here. It doesn't matter what job title we have. We're all here for the residents that we live here and that live here. And I am big on let's shout about what we do well. And at the moment, I'm seeing a lot on telly about what's going wrong. We need to showcase some of that. So I would urge you to get some really great communication going on this, something that, you know, I have to say the council have improved on our communications, and I think that's a good thing. Are there any more comments on the report as Keith has produced it? Does anybody else want to say anything? I think I'm hearing that we all accept the priorities as being what we need. Am I right in that? Because I think what I have to do now is move the recommendations as in the report, and I have to ask for a proposer and a seconder, I believe. Is that correct, Nikki? Yes, it is. She's nodding. Do I have a proposer? Thank you. Oh. Oh yeah, of course. Yeah, no, come on. You don't have to be put your head in your hands.
Well, I'm trying to be really well behaved, and there's people now I don't always manage it, so I'm trying. I was going to go back to actually the demand and capacity piece work, because what I heard you say was actually we don't have the capacity to do that. So I was going to ask, what is the plan to do that? Because, you know, if we're going to right size everything and get every patients looked after in the right place, I do think we needs to know when's that going to happen and how's that going to happen. Thank you.
So there's two prongs to this. So the way we're currently organising services is not as productive as it needs to be. So one element of that is about making the current spend go further than it goes by bringing services together. So let me just give you one example, just to bring it alive. So our rapid response team, they have an average length of stay around 5 days. Okay, the whole model is contingent upon you deal with the crisis, you hand back to neighbourhoods. The waiting time for our rehab is 6 weeks. So those numbers don't stack. So we end up with, forgive me for the phrase, holding tanks of patients. So we think we can do better with the existing resource we've got by bringing work from same-day urgent support, same-day urgent primary care, and by bringing services together. We've also put a bid in, basically to the ICB around the 20 million funding, both for rapid, correct me if I'm right, Vanessa, for urgent community response and for IV antibiotics. The combination of those two, that productivity gain and that bid, we believe, and we're going to use some of the better care funding to support it too, will give us the capacity that we need. We need to get to 7,500 referrals a year to take that 34 down to where it needs to be. So that is the plan, and we're in close contact with colleagues at the hospital and elsewhere to do that. So that is the plan, and we're trying to do that by September. Yeah. Can I just mention, just to summarise one other thing, because I think what I've written down here is what I am going to amend is the point that you made in terms of responsibilities and time scales. I think they're important that we get those in, because otherwise it just looks like, if still in 5 years' time, then actually it's not much of a plan, is it, to do that? And then I think what I will put on is the vaccination uptake. I think we had that in the original uptake rates. I think that is actually quite that is quite important. What I would just mention, because I went through an entire talk without mentioning discharge. Can you believe that? That's unforgivable of me. What I would say, we're facing two challenges in Hillingdon. One is, so we have a phrase called no criteria to reside, and that they are basically people who are fit for discharge and should really be home wherever home is. Yeah. We have a target to get to around 34. Give or take, these not magical numbers, but 34. We hover around the 40 mark on an average. And what we've noticed is that our P2s and P3 are absolute numbers of those have increased over the last 3 to 4 months, Sean. So we've done we are doing a specific piece of work around the P2s. Are we overprescribed? P2s, are people usually who require a period of inpatient rehabilitation before they can go home. We have a suspicion that that's being overprescribed. In other words, people could just go home without having to go into. So we're doing a piece of work on that. The other piece of work, which I wish I had a magic wand on, which we'll come on to, is that actually we have a surplus of discharges over admissions during the week. We have a deficit over weekends. So again, we have to find a better way to manage our weekend discharges in order to bring that into kilter. And that's about 7-day models of care. It's around a whole range of other issues. So there's work there still. We do well compared to North West London averages, but to be honest, the North West London averages are generous, and they won't get us to where we need to be in terms of the hospital redevelopment plan. So I'll give you an example. The P1 average is over 2. We're at 1.6. Actually, nationally, it's about a day. It should be a day. So we're top of the pack. But if you're not in the Premier League, you're in League Division 3, then it's not much of a. So there's work that we just need. There's work that we need to be done, Chair. And I think it's continuous improvement. But there's work still to be done. I think. So I'll pause then with those amendments. Then obviously what we can then do is turn this into a report that we then use. It's the single version of the truth that we use. Didn't want to spoil it. Chief Finance Officers have asked ironically for some more metrics for mental health. And that didn't come from CNWL. So, okay.
Amanda?
I just thought, in the spirit of picking up everything that perhaps needs to be mentioned, you raised in the report the risk around same-day urgent care capacity because of the changing commissioning approach for access at the ICB. I think that risk is now an issue. As you know, Keith, there is additional funding from HHCP for that service, but we've had to essentially persuade our PCNs to continue to fund. And we've got probably about 60% of the funding we had last year. Now, which is not to say that I completely agree with the priorities and completely agree with the targets, by the way, around the capacity that needs to be in that service to deliver some of the things we need to happen at the front door. But at the moment, there's a bit of a reality gap, I think, that may well be mitigated by other bids going on at the moment, so it's not. I think it's probably fair to point out, though, that risk has really come home to roost.
Thanks, Sandra. We will pick that up. Just to put that into context, our 3 super hubs, our same-day urgent primary care, are contingent on having that funding.
Vanessa?
Just on, Keith, your point around the mental health metrics, absolutely, and happy to be of help if we can think about how they link to the work to make sure, because I'm really keen that we have metrics that then link back to the kind of work that we're actually doing.
Professor Goodman?
So this might seem a bit controversial, but if we say that our top 3 priorities are live well, age well, equity and inclusion, we haven't really discussed it. It's all been discussed in the medical model here, and really we need to discuss more about what we can do outside the medical model to get to that sort of target of living well and aging well. And I'm not sure we've got the right focus yet. We've got the right priorities. This is very much a reactive discussion we've had, which is where the money is spent at the moment. But for the future, we've got to think about how we do this in a more holistic way, using neighbourhoods, but try and move away from the focus of acute medical care all the time, because we've been doing this for so long and it hasn't got us anywhere.
As ever, you make a good point. Do you want to reply to that or not?
So I think you're right, Ian. I think the analogy I always use is it's a bit like there's a hole in the dam, isn't it? And the first thing we've got to do is block the hole in the dam. And then we get concerned about, so how did that happen in the first place and how do we stop the dam breaking? So I think we need to do both. But we're shoveling water at the minute, and we've got to try and sort both. So I think what we try to do here with the neighbourhood work is have the balance between, and I'm sure Sandra would agree, the long-term preventative agenda, which is not, you're right, it's not a health issue, it's largely a community asset, third sector, self-management issue, as well as our duty of care to fix acute care as it stands. So I agree, and we're trying to get the balance here between the two. Not always easy, I think.
I think it's a similar point to the under ones going into hospital, isn't it? It's what are we doing out in the community to help. I don't really want to say educate people, but I think there is a lack of this common sense now. Everybody sort of goes into panic, and sometimes that is because they just don't know what's around. So I think we need to do much more to address that. So I support what Professor Goodman's saying, and let's not lose sight of that within this very, very good report. Unless there's anything else anybody wants to say, I'm going to move the recommendations within the report. I think we all agree with the priorities, so all I need really is somebody to second it, and then we can move on. Okay, so that's Professor Goodman, please. Thank you very much. I am now going to move on to agenda item B, which is the Better Care Fund plan submission, which was emailed out to us on the 6th of June. Gary, your baby.
Thank you, Chair. Just to start off, to inform the board that we have submitted and we are compliant with all the national requirements. Just want to give the board a few headlines, and then myself and other colleagues will be delighted to answer any questions that you may have. This year has seen a 3.93% increase in the national minimum contribution, NHS contribution to adult social care. There's a 1.7 overall percent increase in the national minimum contribution overall. 13% increase in the DFG funding. That's the sum total of the increase to the Better Care Fund income streams on 24-25. What other things have changed for 25-26 is the ICB discharge fund, which was ring-fenced in 24-25, has now been included into the NHS minimum and the ring fence taken off, but for the value hasn't changed. It remains at its 24-25 value. Equally, the local authority discharge fund and the improved Better Care Fund, which were two separate income streams in 24-25, have now been merged into the local authority Better Care grant. The ring fence has been removed off the discharge element, but the combined value remains at its 24-25 level. What we have done is restructured the plan to streamline and simplify it, bringing reducing the number of schemes, seeking to reduce the number of different income streams, funding schemes, and this is all in the following on from the North West London Better Care review previously reported to the board. The 25-26 planned value actually reduces to 74 million from 100 million. and much of that is actually down to reductions in additional contribution from the local authority and also from the ICB. In respect to the local authority, that's actually about again rationalising the plan and ensuring that income streams or additional income going in is aligned both to metrics and to the mandated income streams. The report you'll see sets out the priorities for this year, which are very much in line with the last item on the agenda. The submission itself composes of a narrative plan, a planning template which included detail on the financials and also the metrics, which this year there are three. Emergency admissions, discharge delays and permanent admissions to care homes. Important point to bring to the board's attention is the reduction in the ICB additional contribution, which will see requirements to achieve savings by for 26-27 of 1.5 million. Some of those savings are quite straightforward to achieve. With the others, it is those that we are proposing to do separate equality impact assessments prior to making the final decision about taking forward those proposals. I think I'll leave it at that, Chair, and happy to take any questions the board may have.
Thank you, Gary. My gratitude, as always, for your presentation of this report. Vanessa, your hand's raised. Do you want to make a comment?
Yeah, no, thank you. I just wanted to ask about any impact on mental health because I didn't see anything particularly pulled out in terms of discharges, but I just wanted to double check. Thanks.
There's nothing that was in 24-25 that is actually coming out in 25-26.
Leslie?
So thanks, and I do feel for you doing this, I do. So can I just ask a couple of things though? So overall, funding has gone down or stable or up?
Income into the national...
Sorry.
So the income coming into the mandated income streams has gone up. There has been a reduction in the ICB additional contribution. There is funding which has actually come out from the additional local authority contribution, but there have actually been no changes to services. It's just that those services are no longer funded within the BCF.
So thank you. So I think what was welcome this year is that the Centre haven't examined our plans in detail, but they have put those three metrics in. In terms of our approach to those metrics, in terms of the decrease in emergency admissions, the decrease in the length of delay for patients who are discharge ready, and in terms of the long-term placements, I'm sorry, maybe I should know this actually, but what have we said about those things?
What we've done is actually based the targets on the data that we had available about 24-25 activity. For the NHS related metrics, we've put an improvement target of 1% in. There are other measures that we looked at. We were asked to look at, so for example, discharge to usual place of residence, that kind of thing. There were issues about some of the data, but the approach that we took, we thought was sort of realistic on the basis of the data that we had available at the time. There will be an opportunity to review those targets when we complete the Q1 performance update, which we'll need to submit next month.
Sorry, thank you. So this isn't direct, but this is for us actually, which is that 1%, and this is responsibility for all of us. That doesn't just sit here at all. That is unlikely to get us to where we will need to get to for the new hospital, or indeed to fulfil those plans that we've just heard described. So I think it is just worth us thinking together about is there more that we can do, and being a bit challenging with each other about what we do with that money and what works and what doesn't work. And I think and taking a little bit more interest, so not for you but for us, in terms of what might help, and feeding in some of the national work around that if it's helpful. I don't know if it will be actually, but it might be. Thank you.
Keith?
I think to support that, I think if Tony were here, I think he would be agreeing with you, because I think our reflection of the last 12 months in terms of the Better Care Fund is whether we need to be more radical and more ambitious, just in terms of how we do that and how we use that. And I think having a better alignment between the previous agenda item that we just talked about and this here, and how we use the funding to drive that. And I think, certainly the conversations we had over the 1.5 million, I think Tony and Sandra's view was simply, okay, we must be more ambitious in terms of how we do this, and more radical, and be prepared to take more risk. I think is where we need to be on some of this.
Yeah, I think in some ways the 1.5 gave us an opportunity to review, not rolling forward what we've done for years, and to get that over the line has been really challenging. And I think Gary and Sean and Keith have done a sterling job to get us where we need to be, because it's probably the most difficult job in the world to land that in a balanced way. But going through that, taking out that 1.5 and reassessing it, rather than just saying, okay, this is the additional, we'll deal with that, actually realigning everything, which meant these guys had to realign everything, meant that we could see that there are some real kind of areas for target and for challenge. And I think that it's for us not to say it's landed and it's done now, but actually to keep doing that. And as Gary says, as part of our submission for the Q1 updates, we need to keep challenging ourselves to make that difference, because every time somebody is in hospital with you means they're coming to me, and the longer they're there, the harder work it's going to be for us to settle them. So it's a whole system. We're completely in agreement with what you're saying.
Love a bit of unity. Anybody? Yeah, Professor Good.
So I've been attending these meetings for many, many years now, and one of the impressive things when I first started was that Hillingdon was at the forefront of digital support for its citizens and residents, with telemetric monitoring that area, allowing more residents to stay at home and be cared for. And I just wondered, moving on with all the digital innovations we are seeing at the moment, how much we are going to be able to use those innovations in the planning to actually manage the Better Care Fund in a more efficient way. Because we've been talking about being challenged and changing things, but I've been interested to actually find out how much we're using the new digital sort of solutions for these things.
Sandra, do you want to answer that? And I probably will chip in after.
Thank you. So we're in the process of just proposing a digital tech-enabled strategy, which is complete. So two sections. One, how our staff work and how they manage the business and the huge demand. And we've been doing that for about 18 months, and we've got some really good solutions, and just building some new solutions that mean that assessments can be done so much quicker and more per day by individuals, etc. So that starts to turn the business around and get people's assessments in hospital done in a much more slick and enabled way, so families get the assessments, can make decisions much quicker. So that's part one of our digital approach. The second one, and you're right to say, we were forefront leading on telecare 20 years ago, and in many ways tech hasn't moved on very much in the social care space. It's still kind of telecare line is still the saviour of many people of being able to stay at home. But what we want people to move towards now is a lot of how they can help themselves with normalised technology, such as the products you can buy in Argos, etc. But for that, people need good advice, information, support, and to enable people to stay at home. But every day we're prescribing things like sleep mats, epilepsy sensors, door sensors, chair sensors, bed sensors, so that people can stay at home, and they want to, and that enables us to keep people out of long-term care placements. So there is a strategy just about. We'll be hopefully getting it to our cabinet in the near future, which is going to, frankly, social care can't manage the demand without having tech-enabled care supporting individuals, as well as the cohort of people that don't want us interfering in their lives and can do it with an Alexa. So there's lots going on. We're not quite there yet, but the start with the staff has made a huge difference and will continue to do so.
Thank you. So this is a prime example, as Cabinet Member with the responsibility for that. This is a prime example where if I start to talk to residents about technology and social care, they go into absolute nightmare, because how we cascade this as a good thing is sometimes quite difficult. And I know it's nothing to do with health and social care, but the last time the census was done, it was all done on the internet, even though people say they haven't got access to it. So I think we have to be, we have to move into this way. There's a lot that social care can benefit from, and I will be pleased to see a strategy delivered, but I will be asking for support from partners as to how we deliver it to residents, because unfortunately change is not popular, and technology can be quite frightening to older people who still don't use mobile phones, and there are some. So I'll be pleased to see it, but we'll be asking for support from clinical partners. Keith, yeah.
I'm going to put Amanda Kerry McDermott on the spot here. It might be worth Amanda sharing the work we're doing in terms of that reactive care discussion we just had, in terms of taking diagnostics to patients as opposed to being patients to diagnose. So it might be something like that. A little bit of so there are 9,800 patients in Hillingdon who have got severe frailty. They are the people who today will be about to go into care homes, sitting in the hospital and doing things. Okay. So, and Sean knows I'm going to go on this one. So when we did the workshop around reactive care, I said, can I see them? Where are they today? This minute, where are they? Oh, we can't do that. We'll have to go and ask. We can get that from Wiswick, I think. We'll have to go and ask about it. How many weeks later have we had a response yet on that? Yeah.
We have finally had a response. So we should have it by the end of the month. And the Wiswick dashboard is also going to be updated to include our data as well. So, yeah, found out last Friday.
It's just a concept, Chair, that in a proper command and control centre, if this were a hospital, you'd know where all your patients are today. Those 9,800 people, we haven't got Scoobies where those people are today, and actually we should be able to deploy technology, which I think is your challenge, Ian, to help people live an independent life, so that we can actually intervene earlier in that bit, and that should not be beyond our wit to do that. But some of our processes in terms of getting this thing done, bit of a challenge.
I mean, it's a point well made, isn't it? I think we're all smiling and nodding at what's being said. It is a point well made, and I think we need to keep the subject alive around the table. Because we can't be left behind. Sandra?
I mean, it's something that we did probably 10 years ago when telecare was nobody was discharged into reablement or out of hospital without a telecare line installation. Slightly tricky now with the digital switchover, so we're using SIM hubs as opposed to landlines, but everyone then had to have a landline put in and etc. It's easy for us now to be able to say, to discharge somebody, let's put in some technology as part of your we can take it out. We can take it out really quickly if people don't want to have it, but we have to have a strategy that it forms part of their discharge to enable them to go home quickly as part of that whole journey.
Yeah, I mean, digital saves lives. I've just heard an example today of how it saves lives. It can also prevent people help prevent people going into hospital. So it's not just life-saving at the end. It can be there all the time. You know, alleviating loneliness. There's lots of things that can be done.
It's just a comment that it's frustrating that when we work and live in an age of austerity and budgets are being cut, the first thing that tends to be cut tends to be investment in IT and digital.
Amanda?
Just to pick up on Keith's invitation that he made earlier, we are in active discussions about mobile diagnostics. So these would be small sets of diagnostics that can go on the back of a moped or something, as far as I gather, which we were initially talking about whether that could be used in a care home setting where we already run jointly with CNWL the care home service. So it's a mixture of GPs working with matrons and other specialist resources. But actually, the economics of it may mean that it needs to be a bigger cohort, which would actually suit this large, frail cohort that Keith was talking about, because actually it doesn't need to be just a care home if it's mobile. So that's, as I say, an active discussion. Ritu's heavily involved in that. And then just to pick up on the point about WISIC, and Sean and Keith will know that, that's great news, but I think we need to make better use of operational data, because WISIC isn't live. It's taking information, and it's not completely up-to-date information, which doesn't mean it's wrong, but it's not live operational data, and I think we could do more. It is all about the governance around data sharing, and the difficulties of even just getting with partner providers. A thing for a joint service lined up is actually quite challenging, but we kind of need to crack that nut, I think, if we're going to really make neighbourhood working a success.
Okay. Does anybody? You do.
Just to end on a note of levity, we've got a name for the mobile service. Now, it's called Just Treat. I think I'm being serious.
Okay. I'm a little bit stunned at that. Doesn't usually happen. I'm short of words, but I am. Okay. So unless there's any more comments about the agenda item 6 that's just been presented, I'm going to say that the recommendations are that as a board we approve the 25-26 Better Care Fund plan as described in the report, which include the proposed financial arrangements and proposed targets for the national metrics, and we note the position regarding equality and health impact assessments as set out in the report. So once again, I'm going to move those recommendations, and I need a seconder for that, please. Derval, do you want? Oh yeah, I'm going to go to you because you wanted it. Yeah, please. And I'm going to. So, are we all in favour of that? Sorry, I need to just. Thank you very much. So we are. That brings that agenda item to a close. We now move on to agenda item 7, which is the proactive care development update / neighbourhood health. I think that's you, Keith.
I think I covered that, Chair, in the health and wellbeing priorities. I don't think we need any further discussion, unless obviously the board would like a further discussion on it.
I think that's a resounding no, which then takes us on to the agenda item 8, which is the board planner and future agenda items, and so that's just for consideration, I think. So I'm going to. Does anybody want to say anything about that? Do we want to have any discussion about that, or do we accept it? In which case, once again, I'm going to ask for a seconder. I'm just going to say there's no discussion. If we don't want a discussion, we just move into seconding it. That's Vanessa then, please, Nikki. That brings that to a close. So That is the end of the public part of the meeting. Thank you to those members of the public watching on YouTube. Will everyone please remain silent until Democratic Services have confirmed that the live broadcast has ended and the loop has been switched off. Thank you very much. And relax.